So when we think about contrasted media, it is a fairly safe medication or pharmaceutical at this point. And so the things to remember is it really has very little effect for acute kidney injuries. So the clinical concerns, really the main times that I've seen issues is really unstable renal function. But for stable renal function, even with pretty borderline function, really you get away with it most of the time. So this is a different contrast media than 10 or 20 years ago. And so really is pretty low, and especially if you have a GFR less than or a GFR over 30. And again, this is just similar stuff. So the biggest thing, and we can just jump ahead, is when we're thinking about contrast, we have to also think about when we inject it, the different injection rates. And so it's a safe medication, but the biggest thing is we have to think about how are we going to get it and where do we want it to go. So our injection rate has a huge influence in how your peak contrast. So the faster the injection rate, the higher the peak contrast that you're going to get, and then the amount of contrast. So it's both injection rate and then contrast. And a lot of what we'll talk about in a moment when we start thinking about congenital heart disease is we're really trying to spend a lot of time thinking about how do I get contrast to where I need to do for complex situations. But it all comes down to pretty basic principles of how fast am I injecting and how long am I injecting. And then that all is influenced by the cardiac output of the patient. So there's different options in terms of if you're trying to do a kind of a timing bolus versus versus bolus tracking. So if you're watching and giving a little bit of contrast and seeing where your peak contrast is versus if you're just monitoring off of the ascending or descending aorta. It all gets you to a relatively, there's more than one way to skin a cat when it comes to this. And so a lot of it is based on your institution, but there can be some different times in terms of how you adjust things. I really like doing the timing bolus if I can give a lot of contrast. But if we're trying to really minimize how much contrast, and I'm really like the patients with the borderline renal function, I'll often do at a lower injection rate and do bolus tracking just because I can get away with less contrast. And so it's not as pretty of a scan, but at the same time, we can get away with less contrast. So it's really kind of adjusting for the patient. And so the biggest thing is it's pretty safe. We've really moved away from using IV fluids, and that you really have to think about both your rate and the amount of contrast. And we'll go through more details online for you guys from us board studying. Moving on to congenital in terms of how to approach, a lot of this is trying to think about how do we approach congenital heart disease, and a lot of imaging is really based off of, some of it is just what is it and what are we looking at even in adults. So when we think about adults, about 1% of the population has congenital heart disease. That may even be an underestimation. So the only data that I've ever been able to find that's looked at, like if you take like a random adult off the street, it was done in South Korea, where they took people that didn't have known heart disease that were coming in for a general physical, and they did echocardiogram screening for those patients, and they got a 1% hit rate there for just undiagnosed congenital heart disease. And I would say that's probably similar to what I see from just like a routine imaging standpoint also. So it's not common, but it's not uncommon either. So if you're in a high volume lab, you're going to be seeing congenital heart disease that's not been diagnosed, and you'll see it in adults. So it is important to know, to one, recognize it, and then know how to think through it for the imaging studies that you're doing. And so when we think about how to do it, a lot of times the anatomy is the hardest part, and then there's all the other pieces. And so we're really going to be focusing on imaging, but the imaging and the anatomy part, but imaging is really essential to how do we care for patients with congenital heart disease. So the standard really is thinking about a segmental approach where we really look at where's the heart in the chest, and then defining the different components of the heart. So the atrial chambers, the ventricular chambers, the arteries, how do you put it all together? And then are there other associated malformations? And I use this for all different imaging modalities. It's not unique for CT. It really works for everything. So the first thing is thinking about the cardiac position. And I really try to not only use like the actual description, but really describe exactly what you're seeing, because people misuse the terminology all the time. And so I don't actually know when someone says dextrocardia versus dextroposition if they're actually using the right terminology. So I both use the terminology and describe it. So levo position means the chest is in the left heart wall, meso position is midline, and dextro position is it's in the right. And then the second part is the apex, is it pointing left, midline, or right? So true dextrocardia is dextro position with the apex to the right, but people often misstate it. And they'll also call something that's either meso position or dextro position with the apex to the left, and they'll call that dextrocardia. That's not true dextrocardia. So I just encourage people to actually just explain what you're seeing, and then nobody will be confused.